Well, what a great pleasure for us to have both of you here. And I know the weather's out there is not so great, but you made it in time. Thank you so much. So this is a unique opportunity for us to have the discussion with the two senior senators who care so much about this area. Because of a short time, we thought I'll have a conversation with them. I know the aides are going to be here. I spoke to some of them. So throughout the day, you have more chance to speak to the aides and the staff people to actually make sure that we have more dialogue and conversation with them. So thank you again for being here. You know, both of you have been so instrumental in bringing end-of-life issues to national attention. Both senators have advocated for better end-of-life care, and their actions have proved their commitment. They've sponsored or co-sponsored legislation intended to improve hospice care, better line care with personal preference, improve service coordination, and reform payment systems. So that's why we are so pleased that they're here. So if I may first introduce Senator Collins. She is a senior senator from Maine, first elected to United States Senate in 1996, and is currently serving her 4th term. She has had many significant legislative accomplishments in such critical areas as homeland security, national defense, disaster response, education, business development, and healthcare. She now serves on the Senate Health, Education, Labor, and Pensions, the HELP Committee, and she's currently served as the chairman of the Senate Special Committee on Aging. Senator Collins has a long-standing interest in healthcare. She founded the Senate Diabetes Caucus and is the chair of the Congressional Task Force on Alzheimer's disease. She worked to significantly increase funding for research, for which we are really appreciative for both of these areas. She's also exhibited great leadership in restoring critical funding to Medicare so that elderly and disabled residents can receive needed care in their own homes. So thank you so much for your great work. Now, Senator Warner is a senior senator from Virginia. And, you know, his family to graduate from college, and he spent 20 years as a very successful technology and business leader in Virginia before he was elected the governor of Virginia in 2001. When he left the office in 2006, Virginia was ranked as the best state for business, best managed state, and the best state in which to receive a public education. Governor Warner was elected to United States Senate in 2008, where he serves on the Banking, Budget, Finance, and Intelligence Committees. At a time when Washington seems gridlocked by partisan politics, and still is, he's emerged as a bipartisan leader who's willing to cross the political aisle to bring people together and get things done. And indeed, he gets things done. Senator Warner has been recognized as national leader in fighting for our military men and women and veterans, working to design a bipartisan comprehensive plan to address our country's debt and deficit. And this brand of bipartisan cooperation is really what we need a lot more in Washington today. Thank you very much again for being here. So both senators want to tell us their thoughts, and I thought we can begin first with Senator Warner. If you want to spend 5, 7, 10 minutes to tell us what you are doing, what you're thinking about in this area, and then we'll follow by Senator Collins.
Well, thank you, Dr. Dzau. I appreciate the introduction, and it's great to be back at the National Academies. I was here just a few weeks ago for the CTAC conference, which covered many of these same issues. It's also great to be here with my friend Susan Collins. We have worked together on Alzheimer's, where we were both involved in that caucus, and a whole host of other issues. She is one of the senators that we both kind of make up what sometimes feels like a diminishing amount of what we might call the rational caucus in the Senate. But she is... But you know, end-of-life issues are I think everybody brings their own personal story. Mine was, this is an issue that's terribly important to me. My mom had Alzheimer's for 11 years, 9 years of which she didn't speak. My father and sister took care of her, 24/7 around the clock at home. Yet, and when she first got sick, I was governor of Virginia. Yet even as governor of Virginia, we never had that conversation even in our own family. What to do, how do you honor her wishes, how we could have involved her pastor and other things involved in this part of life. So since I've been in the Senate, this has been an area that has been an enormous focus. And Susan and I were both mentioning earlier, there were lots of things in politics that are statements that are over the top, but probably nothing has been more irresponsible throughout that whole healthcare debate than the comments from the lady who could see Russia from her window about death panels, which put a fear, I think, in many elected officials that this is a subject that we can't talk about. I think that time has passed. I think this is clearly an issue where the public is ahead of the policymakers. And for 2 years, I introduced, for 2 Congresses, the Senior Navigation Act. Last session of Congress with Johnny Isaacson, another great leader in this space, a Republican senator from Georgia, we introduced the Care Planning Act. And let me tell you briefly about it. A lot of what is in the Care Planning Act really comes out of the recommendations that the IOM made in your report. First of all, it says, in a healthcare system where we're willing to compensate doctors for whatever test or procedure you want, whether it is appropriate or not, yet we don't have a system where we compensate a doctor or a social worker or a nurse practitioner or a team to have the kind of conversation with a family about choices as people with advanced illnesses go through that phase of life. We have created, and I know CMS is already working on some of this within the existing kind of coding system, the ability for a team approach to have that conversation with the family member, with their loved ones, with the religious advisor if they choose, but to make sure that conversation takes place and is appropriately compensated. Point number one. Point number two is to recognize as we think about persons' choices, if they have had that conversation, and how they're documented, whether it's a living will, whether it's a post in terms of from a doctor's position, whether it is an advancce directive, we've got to make sure that those are actually portable and put in to the medical records. Too often, mom or grandma may have had that conversation when she lived in Illinois, but when she's now moved in with their kids in Virginia, that directive doesn't follow. And we've got to make sure that directive follows as well. Third thing we do in this area is we say, we've not tried to limit these services. We think we ought to try at least an experiment to limit, and I'll call it hospice light services, so that we're not just in the phase of life where people have moved from the curative phase into the hospice area. How do you think about some of these wraparound services in an earlier period in a person's advanced illness? And finally, the last two things is to make sure that we try to make sure we have better data. How do we make sure we follow quality of life as people make these choices? And then how do we make sure that we do a better job of educating the public about this opportunity? At the end, though, this is about increasing choices, not decreasing choices. It's about making sure that people can make responsible decisions and get the health care they want. No more, no less. And frankly, I am very much believe that the time for legislative action is now. I think the damage that was done and some of the fear that was installed a half dozen years ago has moved on beyond what people care about the ACA, good, bad, indifferent. This is a space and a time, I think, where legislation, whether it's this act or whether it's a piece that Susan may have, I think people in that rational caucus should come together and make this Congress the time that we take on and have this conversation. Final point I'd simply make is it's remarkable to me that we're the only industrial nation, modern industrial nation in the world that's not had this kind of adult conversation. Every other country in the world has been willing to talk about this phase of life. We are sadly absent from that, and I think to put meaningful legislation in place that would advance, frankly, what you all do as on the front lines of living through the failure to have a system that allows these kind of choices is quite honestly inappropriate in a society as advanced otherwise as ours. So I look forward to seeing how we can work together further and hopefully move this from what we should do to what we actually have. Thanks.
Thank you very much. Senator Collins?
Thank you. First, let me say that it's a pleasure to be here with my friend and dear colleague, Senator Mark Warner, a member of the Rational Caucus. I actually, coming from Maine, call it the Common Sense Caucus, but it's one in the same group. I also want to congratulate the Institute of Medicine for your landmark report that came out in September on dying in America. It really outlines many of the challenges that we face. I believe that these challenges fall in three categories. They're philosophical, they're practical, and I've forgotten my third P, but now what is that a sign of? But let me talk about the philosophical issues first. I've always been struck by a line by the noted healthcare economist Uwe Reinhardt, who said that Americans are the only people on earth who think that death is negotiable. And I believe that there's still a lot of truth in that. Many Americans fail to plan for their inevitable demise. Many healthcare providers are reluctant still to bring up the issue. And as a result, and this is the sad result, too many Americans are dying in situations that are inconsistent with their wishes, with their desires. And often that end-of-life care occurs in a hospital environment tethered to high-tech equipment and really isolated from family and friends. And yet every survey shows us that Americans would much rather die at home. There's also a problem with our practical approach, and that has to do with our reimbursement policies, which Mark touched on, but also with the fact that physicians, at least in studies that I have seen, have been reluctant to talk about hospice care and are inhibited by the requirements under Medicare that hospice care requires healthcare providers to predict the death of their patient. And hospice care is supposed to be when you're in the last 6 months of life. And it's just not that precise a science. As palliative care physician Dr. Ira Byock has observed, hospice was designed to provide end-of-life care, but in reality, it's brink of death care. And the statistics show that most individuals go into hospice care within 2 weeks of their dying. Now, what a loss that is. In Maine, we have a wonderful hospice house in southern Maine called the Gosnell Memorial Hospice House. And I have visited a dear friend who died there. It is a home-like setting. She was one who could not receive care at home. And I remember one day when I was visiting her, and out of the blue, she said, "You know, I'd really like some scones." And sure enough, one of the staffers at the Gosnell house went out and bought her scones. Where else would that happen other than in a hospice-like environment? And I thought that truly was the veritable definition of patient-centered care. Now, when Senator Jay Rockefeller was in the Senate, he and I worked together to write the law that did require reimbursement for a discussion of end-of-life care during the Welcome to Medicare physical that is available to new beneficiaries. But although we have made a lot of progress, there are still the third P, political obstacles to expanding the discussion of end-of-life care. I totally agree with Mark that death panels was so irresponsible a statement and stopped in its track legislation that we both had that would have expanded Medicare reimbursements. Last year, the then chairman of the Senate Aging Committee, Bill Nelson, and I wrote to Medicare and encouraged them to establish codes for discussions of advance directives and end-of-life care discussions. I've also seen the difference that those discussions have made, and I will say in the state of Maine, we're making tremendous progress in that area, which I'm very proud of. In fact, at my annual physical in December, I was chastised by my primary care physician for not having my advance directive and power of attorney as part of the St. Joseph Hospital's record, electronic record on me. When I subsequently went for 2 procedures in the hospital, I was asked each time why I hadn't brought them in. I don't know what they were expecting the outcome of those procedures to be. But actually berating me about this issue did cause me to bring the records in, and now they're scanned in and part of the hospital's records. So I think it takes a cooperative effort from everyone involved. We need Medicare to reimburse. We need families to have these discussions, which are particularly important when someone is diagnosed with Alzheimer's or another cognitive disease, that those discussions, frankly, they should occur before that even happens, but they definitely need to occur at the diagnosis stage of cognitive diseases. And we need to make sure that healthcare providers do not shy away from these discussions. Let me end by just saying that one physician with whom I'm very close told me that when he was in medical school years ago, he spent exactly one day studying palliative and end-of-life care in his whole time in medical school. Now, I know that has changed now, but there are still, or at least I hope it's changed now. If it hasn't changed now, it needs to change now. But many physicians were trained that way, and they can't get past the model of somehow it's a failure if you can't cure. And they need to transition to understanding that helping people deal with the end of life is just as important. So together, I really hope we can make a difference in addressing an issue that each and every one of us will have to face. Thank you.
Thank you. It's really encouraging and enlightening to hear both of you. And I think if you look at the attendance here, and I'm told that we have 1,000 people registered, a lot of people on webinar, despite weather, I would say we're representing everybody that cares about this area, from patients and advocates to educators. We have a previous dean, in fact, at Stanford, to providers, AMA, nursing, to payers, Aetna, to Medicare. We're all here for the same reason, and we thank you for your leadership. So as I hear both of you talking about the issues, I think it's fairly clear that the question is what's in the way, right? So let's talk about advanced care planning. I think both of you, in fact, co-sponsored the Advanced Planning Compassionate Act in 2009. And you actually directed the Secretary of HHS to develop an online clearinghouse and online toolkit to provide comprehensive information about advanced care. So tell us a little bit about, can this in fact be resurrected, what really happened to it, and help us think about how we can move forward with this really very important initiative. Senator Collins?
CMS has said in response to the letter that Senator Bill Nelson and I sent last year that while it was too late for the Medicare codes for this year, that they are looking at doing more in the reimbursement area. And I think the clearinghouse, the toolkit, the portability of advanced care directives, very important in my state where we have a lot of snowbirds who go to Florida in the winter, are all very important. But until we solve the reimbursement issue, I don't think we're going to make true progress. So that's what I really think is most important. Having those tools out there, having questionnaires, having advanced directives, having standard forms, trying to encourage states to honor the forms that are filled out in other states, but also to adopt similar forms or best practices are all important steps. But to me, the most important step is the Medicare reimbursement.
That's great. Please.
Let me add as well. I think it is going to take legislative change, and that's why the Care Planning Act, I think, is one tool. And I think we need to do a couple things. In the 5 or 6 years that I've been working on this, I know that we almost have to, I've been schooled by staff and other experts to move from calling this end of life, not call it that any longer, to senior planning, not call it that. Now it's just care planning. So evolution of language, I think, is important. I think it's also important, as Susan mentioned, that for a lot of doctors, this is an uncomfortable conversation. And that's why I think we really need to think about more of a team approach, where you've got access to a team that might be a series of conversations that would include a doctor or someone from hospice or a social worker, so that you really have somebody who candidly understands how to form these conversations. Doctors should be part of it, but I'm not sure doctors who I think, again, Susan hit it right on the head. I don't think palliative care training has advanced. There's a great field of palliative care, but I don't think as a normal course that is where still a lot of docs are at. Third, I think we have to acknowledge something that is uncomfortable to acknowledge, and I say this with respect to those of you who are representative of provider systems hospitals, but for a lot of hospitals, death is a profit center. Because you have that absent relative who somehow now feels guilty that they've not seen grandma for 3 or 4 years and says, do it all, regardless of grandma's wishes. And, again, in the Care Planning Act, if that's what grandma wants, grandma ought to get it all. Nobody's talking about restricting anybody's choices. But we are saying if there's had this conversation to respect grandma or mom's wishes. And I agree with Susan that it starts with the reimbursement. And I know that CMS has been talking about doing this. I think the only way we're going to get it across the finish line is with a legislative change. And again, I think this is, in the work we've done, we've spent an awful lot of time with the faith organizations, moving them. Most of them are supportive at this point. We've got some that have been reluctant, at least kind of to neutral, which may be as far as we can get with some. But I would just encourage us that this is a time that we all ought to stop talking about it, and those of us who are allies on this up on the Hill really need to make a legislative effort.
Could I just one point to that? And this is in my category of an obstacle that is both practical and political. And I know it's going to seem into the weeds and esoteric to many of you who are in the real world. But an obstacle is the scoring process of the Congressional Budget Office. Mm-hmm. When we require Medicare to reimburse for more services, such as discussions of care planning, I'll use the right term here, that causes Medicare costs to go up in the eyes of the Congressional Budget Office. In fact, I would argue costs will go down. I am convinced that we will have higher quality care that is more in keeping with the patient and family's wishes, and that will be less costly. But the way that CBO scores bills, it will just show an increase in cost. It will not take into account the fact that high-tech hospital costs is the most expensive kind of care.
Right.
And the challenge, and Susan is 100% right on this, but if we try to talk about this in a legislative framework and ever raise the issue that this is actually a cost saver, you then get our opponents to say, aha,
Death
all you're
penalty.
trying to do is take away choice. So it's.
I want to be sure that we also participate in this solution, which is tell us what we can do to help you do your job. Tell us that we as a collective group, how can we actually, I mean, after all, as you said, Senator, there are data out there that shows hospice care give you better, longer life, in fact, at low cost. Are the health economists not helping in thinking about redoing the CBO prediction? What can we do as a group to actually move this needle?
Well, I think what you can do is, we need to see as broad a coalition as possible to put the word out to your respective members of Congress that this is not a partisan issue. This is about quality of life. It's about giving people the health care they choose, no more and no less. And whether it's the Care Planning Act or whether it's an act that we could, Susan and I could come up with, we've got bipartisan support. On a practical basis, and this is one of the reasons why, Susan and Johnny Isaacson and others, I think it has been harder in the last few years for Republican members to get involved in this, because it's somehow gets affiliated with the whole ACA debate. We ought to separate this from the ACA debate and make this a humanity debate. But I think everybody for years were a little bit afraid that this was too hot to touch. Every family in any group I've ever spoken to, and I talk about this a lot, every family's got a story. So I think, again, this is where people are ahead. But we're going to need you all to help step up, and particularly if we can bring more of the faith organizations along. That is that's a really, really important component.
Well, Mark's exactly right. What this is going to require is a broad coalition of healthcare providers, of senior groups like AARP and others, and of educational institutions. It's going to require that kind of cross-cutting group to come together, and it's also going to require education of the public on the point that Mark has rightfully emphasized twice. Nobody is talking about taking away care, taking away choices against the will of the family or the patient. Instead, what we're talking about is honoring their choices at the time when a cure is no longer possible. And that message, I think, still needs to be sent with more clarity. If you want to be in the hospital and have every possible thing done to try to prolong your life one more minute, you should have that option. And so we need to get across the message that this is all about honoring the wishes of the individual.
Yeah, I think if you look at the report that IOM put out, I think a lot of these elements were there, recognizing that it's patient's ownership, much better training of our clinicians, being able to know how to have that conversation, how to, in fact, understand use of hospice and palliative care. But one area that actually was pointed out is the need for integrating social and health services. We certainly see that. A lot of support services don't get paid, and in fact, we are a fee-for-service. And when patients are either in the hospital setting trying to go to, say, a nursing home, or being, staying at home and wanting social services, guess where they go to? Emergency room, because they have really no other place to turn to. What kind of things can we do to make sure these services are integrated? Because, as you said, they're all about caring for the patients holistically, right, and not in a fragmented fashion.
Well, I agree that we need this full integration. But remember where we work. So if we could get this small step of having the collaborative conversation reimbursed, as Susan said, if we could get the ability for the advanced directive to be portable and make sure it's put into that medical record, and we could start down the path of continuing to collect better data and public education, that would be a giant step. And then I think out of that would come even more indication and more acceptance that maybe this the collaborative approach on further reimbursements is, again, not only in the best interest of the patient, but also saves money.
I want to give you a very specific example. Senator Jean Shaheen of New Hampshire and I teamed up to try to have better transition between when people are discharged from a hospital and when they go home. And the goal was to prevent unnecessary rehospitalizations. And we got some language in the Affordable Care Act, but this is something that we've been working on. And what studies have found, and the initial experience has indicated, is that if a case manager is assigned to a recently discharged patient, and if there is one visit by a home health nurse to ensure that the instructions are being followed, that they were understood, that the medications are being taken properly, it makes a tremendous difference. That, to me, is the best example of integrated care. that improves outcomes and satisfaction, and again, I would argue, lowers cost.
Right.
And remember, we've also, and your keynote speaker, when a tool comes up, what's been the best-selling book in America for weeks and weeks on end?
Right.
You know, there is this moment now where I think we are far enough away from some of the scare tactics. There is a growing recognition. You know, we've got someone extraordinarily articulate on the subject that has humanized this for a lot of Americans. It would be a shame if we didn't try, at least in this year, to try to move something that actually could become law.
You know, the other reason this is the time is the changing demographics of our country.
Right.
We are living longer and longer, and these issues are going to become even more important. The oldest old, 85 and over, is the fastest growing part of our population. So these are issues that are going to become increasingly important to the Medicare and Medicaid programs and to our public policy as well as our personal lives.
Thank you so much. Now, I just, really wonderful. So I'm seeing the time is short, and I know you have to go to other very important activities. Senator Warner, I think you said 2 weeks ago, you were right here at the CTAC meeting saying the time is right? So I just want to ask both of you, Senator Collins and Warner, what are your now plans in terms of moving to the next step? Are you introducing any specific actions, bills, legislation, and how can we help? As you said, we can all work together with you.
Johnny Isaacson and I have this Care Planning Act. You know, we started with the two of us. You know, Susan is actually, as chair of the Aging Committee, our first target to try to, you know, if she's got ways to amend or change it, you know, or if she's got a bill, we need to come together on a single vehicle that may not solve every problem in the world, but could at least move the ball forward. And you know, I'm prepared to work with anybody, you know, Republican, Democrat, Independent, Libertarian, Vegetarian, you name it, to get it done.
I think we need to proceed on two tracks. Legislatively, where we are going to be working together, but also by putting pressure on the administration. Because there's a lot that can be done administratively here through CMS. And I think that they have been very slow to respond.
Yes.
I also am very concerned that the administration, year after year, keeps promoting and proposing cuts in the reimbursement for home health care and hospice. That's the last thing that we should be doing. And when I have brought this issue up, I'm always told, well, there's fraud in home health agencies and hospice providers. If there's fraud, you go after the bad apples. You don't slash the reimbursement for everybody. So I think a two-track strategy is absolutely necessary. Next week, the Aging Committee, which I do chair, will be holding a hearing on Alzheimer's. We'll be looking mainly at research and the possibility of breakthroughs if we would do a better investment. We spend, I don't mean to get off track here, but we spend $214 billion a year caring for people with Alzheimer's, of which $153 billion is from the Medicare and Medicaid program. It's fast becoming our costliest disease. Do you know how much we spend on research? It's only $600 million a year. That is crazy.
That's great.
That makes no sense whatsoever. The experts tell us we should be spending $2 billion a year in order to get the kind of breakthroughs that would make a real difference. If we spend $2 billion, that's still less than 1% of what we're spending on care. So this hearing is focused more on the research effort and the need for more investment, but I'm sure that we will have later in the year the hearings also on healthcare planning, and we will try to shine a spotlight on this issue. I think that's really important as well.
And the last thing I would add, we need you to not only contact your members of Congress, but as people on the front lines, write that op-ed, write that letter to the editor. Get this, we've got to elevate this issue and make this conversation safe to have.
Well, listen, thank you so much for getting us off to a great start. Thank you for the great work that you do.
Thank you.
Thank you.
Thank you very
I'm going to
much.
come by and talk to you about Alzheimer's.
Okay.
Yeah, no, really. Thank you so much. Really wonderful. Thank you.
Thank you.